లైవ్ స్టార్ట్ అయింది.
ఏమన్నా
ఇక్కడ వస్తే లైవ్ చాట్ వస్తుంది సార్, అటెండెన్స్
కొంత
వస్తుంది.
వాళ్ళ వస్తుందా? అది చూసి మనం పెట్టుకుని సరిపోతున్నాం కదా.
మీరు చేసుకోవచ్చు, ఇంకా వాళ్ళతో సంబంధం లేదు.
ఇక్కడ ఎవరితో కనిపించినప్పుడు దెన్ గో బ్యాక్ టు ప్యూర్.
ఇంకోటి ఇస్తున్నారు చూడండి, వచ్చేస్తున్నారు అందరు. మీరు స్టార్ట్ చేసుకోవచ్చు.
ఇది లేకుండా ఇదే ఫుల్ ఉంటే పర్లేదు. ఇది లేకుండా నెక్స్ట్ స్లైడ్ ఏమొస్తుంది మనకు అంత అవసరం లేదు. Good morning. Sorry, there were some technical problems. That's why the class was delayed. So today we'll discuss something about bone tumors. All of you know that bone can also be afflicted with these carcinogenesis. Sometimes these growths can occur in the bone. Then we tell that even the bones have tumors. So those tumors can be benign or malignant. So in this class we will see some of the benign bone tumors which can routinely occur and how they present themselves and what will be the clinical features, how do you diagnose them and how do you manage. Coming to the differences between benign and malignant, all of you know that a benign tumor is having a good prognosis when combined with a malignant tumor anywhere in the body for that matter. Same thing applies even here in the bones. So the benign tumors are usually slow growing when compared with a malignant variety where the growth will be very, very rapid. So if you can see a patient who has symptoms, say for the last 1 week or 1 month, and now the growth is there and the symptoms are severe, then you can think, even with the history itself, you can say, could this be a malignant variety of bone tumors? And if you find a swelling which is there for so many years, is not causing any symptoms, it's only an unsightly appearance, then probably it could be a benign tumor which grows very, very slowly. And these benign tumors are very well circumscribed. Circumscribed means they are very easy to delineate. You can easily make out the dimensions of the bone tumor. If you can make out that the length is so much, the breadth is so much, then it could be a benign tumor. These are all some general rules. It doesn't mean that 100% true. So there are always exceptions to the rule. Whereas in case of a malignant tumor, usually it is not well circumscribed, because as the growth is very, very fast and the cell turnover is occurring very rapidly, then what's there today may not be there tomorrow. So it keeps on changing. The dimensions will be changing and you may not be able to completely describe a swelling as you can do in case of a benign tumor. And a benign tumor, as the name itself suggests, will not invade into the surrounding tissues. Whereas a malignant tumor, it once breaks loose of its confinements. So usually if a malignant tumor occurs inside a bone, so it spreads in the medullary cavity, both above and below. And all of you know that this cortex is covered by, bone is covered by periosteum outer side. So even the periosteum can be breached by the malignant growth. So once periosteum is breached, then the tumor can come outside the bone and can spread into the surrounding soft tissue. So an invading malignant tumor can be seen outside the bone. It starts inside the bone, but as it grows, it has a propensity to destroy everything in its sight, and it can come out of the confines of a bone. And a benign tumor, as we have already seen, will have very few or no symptoms. A bony swelling which is there, it doesn't cause any pain or no tenderness. It doesn't grow very aggressively. So it could be a benign tumor. But one which is associated with pain and disability, most often it could be a malignant bone tumor. And benign tumor, with very few exceptions, will not metastasize. You all know what is a metastasis. So it's a having a same lesion away from the parent lesion. That means the primary lesion could be uh, the bone, and the metastasis can be found in distant organs, say like a liver. And a common example of bony tumor or secondaries in bone from primary is uh, prostate gland. In prostatic cancers, you may have a bony secondaries with sclerotic secondaries. In breast, in other organs, you can find some bony secondaries. Similarly, a primary bone tumor can have secondaries in the liver. So it all depends on the type of growth which is there and how it spreads. And the common investigation which we routinely resort to in any bone lesion is the X-ray. And in X-ray, the benign condition shows to be confined to the bone because it is a slow growing one, and doesn't metastasize, and it is a well circumscribed lesion. Usually that is confined to the bone itself. But a malignant lesion, on the other hand, on X-ray, it's shown as an ill-defined border and mottled appearance. It doesn't look clean, like the bone appears diseased, and sometimes the cortex may be broken. As I told you, once the cortex is broken, the tumor can spread to the surrounding soft tissues. So, in any patient with this type of X-ray picture and a history of some pain, disability, and a growth in the bone, most likely it could be a malignant tumor. And a benign tumor, in most cases, will not kill the patient. But a malignant tumor could be a osteosarcoma or an Ewing sarcoma. These things can kill a patient. So they are so malignant that by the time you diagnose, it will have metastasis in different organs. So that may lead to the organ getting damaged, and the function of the organ is not optimum, and the patient may be killed because of that. So by the time we diagnose and time we start managing a malignant bone tumor, it could be too late. So you should have all these things in mind whenever you see a bone tumor, and if it is a malignant variety, you need to diagnose it very fast and institute the treatment as early as possible. Coming to there are various types of bone tumors and origin of the bone tumor. So the cell of origin, depending upon from where it is arising, then they are named after that. So if there are some tumors which arise from vascular tissue, they are benign tumors, no doubt. The vascular tissue present in the bone, that is angioid tumors. We call them angioid tumors. And the nomenclature could be an angioma or an aneurysmal bone cyst. We commonly call it as ABC, aneurysmal bone cyst, or it could be a glomus tumor. So, in all these tumors, the cell of origin could be from angioid tissue. So, these are some of the benign tumors which arise from angioid tissue. And there are some benign tumors in which there will be some new bone formation. So those are called bone forming tumors. The bone forming tumors which are benign are osteoblastoma and osteoid osteoma. So all of you should have an idea. If somebody comes and tells you that this is a case of osteoblastoma, as the name itself indicates to you, osteoma or osteoid osteoma or osteoblastoma, something to do with bone. So there may be a bone formation here. So whenever you say bone formation, you can imagine the X-ray with some sclerosis where there is some evidence of new bone formation. So as soon as somebody tells you the name, you should have an idea that this tumor is arising from these cells. So because this bone is arising from these cells, the symptoms can be different or the locations can be different. So once you know and once you read this way, then definitely you can know something about all the tumors even when you don't prepare well for those things. So now you know that osteoblastoma and osteoid osteoma are bone forming tumors. Bone forming tumors. Next one section deals with a cartilage forming tumor. So as and when you say a bone, then definitely a cartilage is also closely associated with bone. So when a tumor can produce bone, then you should have a tumor which can produce cartilage as well. So all of you know that if a cartilage is spoken to, it is some related to this word chondroma. So chondroma means cartilage related to cartilage. So cartilage forming tumors are osteochondroma and chondroblastoma. And some tumors occur in bone and in the teeth also. So there are two common, some cells are there. So these lead to similar type of tumors, especially in the teeth and also in the bones. So tumors arising from dental and elite structures. So bone is also an elite of dental. They are more or less similar in some aspects. So this is, if it occurs in the dental teeth, then it is called odontogenic cyst. So you get to know dental cyst and dentigerous cyst in gen surgery. And this emeloblastoma usually can occur in bone as well as in teeth. And if there is some embryonic vestigial tissue is there, that can also lead to some bone tumors. We'll come to that later. And if the bone tumor, the cell of origin is fibroblast, then we call them as fibroma. And the cell of origin, if it is heterotrophic tissue, then it is called a dermoid. Most of you know by now, you must have read about this in dermoid. Dermoid is quite commonly seen in most of the locations on the body. So it can occur even in the bone, very rare. And lipoma, non-osseous connective tissue like fats, in fact lipoma or neurofibroma or neurilemoma. Neurilemoma is the tumor which can occur from the coverings of a nerve. So these are some of the nomenclature which all of you should know. So if the tumor is arising from synovium, then you can, the cell of origin is synovial tissue, then it could be a synovioma, or chondroma can also be seen from synovial tissue, or undifferentiated connective tissue can lead to osteoclastoma or a giant cell tumor. So we will discuss all these things as and when we come to them one by one. So this is about a general idea about the cell of origin of so many names. So we You are bandied with so many names. We hit you with so many names, but you should not get confused. So once somebody says this is a benign tumor, so immediately you can relate to it by just knowing the name. Osteoblastoma, then you can think that yeah, this is a bone forming benign tumor, like that. Coming to the benign bone tumors, which are very important from the clinical point of view, usually is osteochondroma, chondroma, chondroblastoma, chondromyxoid fibroma, osteoid osteoma, aneurysmal bone cyst, and unicameral bone cyst. So don't get confused with so many names. So once you start getting familiar with these things, they appear very easy for you. So this diagram, this is about a bone, and all of you know that the bone has epiphysis and metaphysis and diaphysis. So there are some tumors which have a predilection to occur in diaphysis, and there are some lesions, bony lesions. They could be either benign or malignant, but they have some predilection to be present in the metaphysis. Similarly, in the epiphysis. So this is a diagram in general which can show you the predilection of these commonly occurring bony lesions. I don't call them benign bone tumors. There are some malignant bone tumors also here. So metaphysis, you can see this is osteosarcoma. This is osteosarcoma which is occurring in the metaphysis, and it can go into the epiphysis as well. So this is a GCT, otherwise known as giant cell tumor. Okay, so it usually occurs in the epiphysis and onto one side. So this is a general diagram, and if you can make yourself familiar with that, any bone tumor, if any question about any bone tumor, then you can draw this diagram. Once you draw this diagram, then we come to know while correcting your papers that yes, this student has done some has some idea about various bone tumors and the common location. And if you don't know anything about the bone tumor, once you write this and go on describing each one in brief, then definitely you will get the pass marks. Today we will discuss something about the commonest benign bone tumor which can be seen in the clinical practice. This is called osteochondroma, otherwise known as exostosis. Osteochondroma or exostosis is a benign, common benign bone tumor, and this is the tumor. Here in this pictorial depiction, you can you can see that cauliflower-like growth on the outside the bone, which is in contact with the bone. So this is a osteochondroma, and as the name itself suggests, it has both a bone and a cartilaginous components, and the swelling is a bony swelling, and the cap is cartilaginous. So from this diagram you can clearly see that the medullary cavity from the main bone is continuous into the growth itself, and the end of the growth has a cartilaginous cap. If you remember those two, then you know everything about osteochondroma. So the medullary cavity of the main bone is in continuity with the medullary cavity in the swelling, and there is a cartilaginous cap. And commonly, where does it occur? So this is the X-ray which shows you that the growths of osteochondroma growths in various bones. Here you can see a knee joint showing the lower end of femur and upper end of the tibia. And you can see the growth plates, they are named there, and you can see the growth over there, osteochondroma on the posterior aspect of the femur and an osteochondroma on the posterior aspect of the tibia. What is the common location? So usually they occur in areas of tendinous attachment. So whenever a tendon comes and gets attached to a bone, there is a predilection of osteochondromas forming in there, and commonest is lower end femur and upper end tibia. So most of the swellings usually they occur in the lower end femur and upper end tibia. Why these osteochondromas come into existence? There is no specific theory about this, but the two theories are suggested. So it can occur at the points of tendinous insertion that we have seen previously, because there is some accumulation of embryonic connective tissue which may lead to epizode growth, and it will lead to a tumor like formation. That is one theory. And the another theory is the persistent cambial layer. If it is persistent throughout the life, then it will form cartilage and bone, and it may lead to osteochondromas. So these are some of the theories bandied about the origin of osteochondroma. So how a patient will present to you? Usually patient comes to you telling us that there is a swelling, and it's not painful. Usually it's not painful, but pain usually occurs, that depends upon the where exactly it is situated, or if it is big in size, or if there is any pressure effect on the other surrounding organs, like pressure over a bone, or pressure over a nerve, or pressure over a vessel will lead to secondary effects, or there may be some bursitis, so which will lead to some pain. Otherwise they are very slow growing and they appear as a bony swelling without any pain. Usually they don't cause any symptoms, and even patient also doesn't bother. So this patient has this growth and he doesn't have any symptoms except that there is some swelling. You can feel the swelling, and the swelling is in continuity with the bone, and you cannot move it apart from the bone. So this is a typical osteochondroma. This is another osteochondroma from the upper end of the fibula. Most of you know that this is a knee joint X-ray which shows the lower end of the femur and upper end of the tibia, and this is the fibula, and the head of the fibula is transformed into an osteochondroma, and it is usually a non-tender swelling present in the metaphysis. Usually this is there in the metaphysis and is directed away from the growing end of the bone. So as the bone grows along, so this is left behind, so this is further away from the growing end of the bone. Okay, and if it causes an inflamed bursa, because all of you know that there are some bursa near the joint. Bursae are there to prevent some friction while moving the movement occurs in the joint. So these bursa can themselves may become inflamed, bursitis. So the bursitis may be because of irritation by this bony tumor. So there may be some bursitis, or it can block some movements, because this is the growth is more, then definitely it can hamper some movements. Then it will come into picture and become symptomatic. Otherwise, this is a non-painful, non-tender, harmless swelling. But pain can occur when it gets fractured. So once there is a growth here, and this is an abnormal bone, this is not a normal bone. So usually fractures can occur in an abnormal bone. Those fractures are spoken to as a pathological fracture. So when a pathological fracture occurs, then there will be pain. So till now, patient had this swelling, painless, immobile, non-tender. All these years, for 10 years he had this near the knee. But suddenly yesterday, when he fell down, he had severe pain. So once you take an X-ray, similar picture may be there with a fracture. So one of the arrows here, lower arrows, can show a fracture. If there is a break there, then there could be a fracture, which will lead to pain. Or if there is a bursitis, then it will lead to pain. Or very rarely, this benign tumor can turn malignant. Then it will lead to pain. So these are the conditions which can lead to a normally docile, benign, non-tender swelling giving problem to the patient, being painful. So If there is a fracture, if there is a bursitis, or if there is a malignant transformation, then only patient will have pain. Otherwise, there is no pain. If you take an X-ray, then this is a typical example how it can be seen. So you can see in the top X-ray, it will be like a mushroom. But in the lower X-ray, in another patient, there is some difference between the top X-ray and the lower one, that in the shape of the tumor. So in the top X-ray, you can see a stalk. You can see a stalk and a head. So this is called a pedunculated. This is called, a top one is called a pedunculated tumor, and the lower one you don't find that stalk. If there is no stalk, then we call that as a sessile swelling. So if there is a stalk and a pedunculated swelling like in the top, then you can on your clinical examination can feel a space between the main bone and the swelling. So that's how you can clinically make out whether the swelling is pedunculated or sessile. But the lower X-ray, it is a sessile bony tumor where you cannot insinuate your finger between the bone and the swelling. So that's how you differentiate clinically. Even before the X-ray comes, you can have an idea whether this is a pedunculated tumor or a sessile tumor. And the tumor has both a cortex and a medulla, and this medullary cavity is in continuation with the main medullary cavity of the bone that we have already emphasized. Coming to some clinical examples, here this is a X-ray of the knee joint wherein the swelling was here in the joint, and this is a post-operative swelling. So during surgery we took it out, and this is the clinical specimen. So how do you treat? How do you treat these osteochondroma or exostosis? Usually, mostly this is a cosmetic in appearance. Usually that may be there. The child's parent must have seen it when the child is around 5, 6, 7, 8 years old. And as the child is growing, in sometimes it can grow or it may not grow very fast. But usually the children are brought to us, usually if they are girls, they are brought near when they are in the early teens, because patients are worried cosmetic appearance, and even the parents nowadays, because everybody are aware that it could be something serious. That's why they bring them, and once you clinically examine and do all the investigations, then you can tell them that this is nothing serious, you can wait and watch. If there is any problem like a mechanical block of the joint, so movements are restricted, then you can plan for surgery and remove it. Or if there is any associated bursitis which is very painful and which is not allowing the patient to move the joint and do their normal daily routine, then you can think of taking it out. Or if there is a fracture of the stalk, so this X-ray we have seen, and there is this stalk, it can get fractured sometimes, then that will become very, very painful. Then you need to operate on that patient. Or if, when it is growing, if it is pressurizing any related neurovascular structures which are nearby, then if it is pressing on the nerve, there may be dysfunction of the nerve, there may be some pain, or there may be some tenderness. That depends upon the what fibers are getting pressed and how much is the pressure. So if you find any pressure or on a vessel or a nerve, then you can plan to remove it. Or if it is getting into malignant change, so very rarely this can transform itself into a chondrosarcoma and sometimes into osteosarcoma, because this has both cartilage and bony parts. So these two are common malignant changes which can occur here in osteochondroma. Osteo will lead to osteosarcoma, and chondro will lead to chondrosarcoma. So chondro part of osteochondroma, if it becomes malignant, it becomes a chondrosarcoma. Similarly, the osteo part, if it becomes malignant, it will go on to become an osteosarcoma. And most often in our clinical practice, we operate on this mainly for cosmetic reasons. We tell the patient, so it doesn't bother, you need not get an operation. No, 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 sir, my child is not comfortable, her friends are ridiculing her, or she is finding it awkward. Then definitely we can subject them for surgery. So you can, so this is the end of the bone which is has the tumor, and we can take out the tumor. We do what is known as a en bloc resection. Along with the tumor, we take out a part of the normal tumor, and always make it sure that the cartilage cap should be removed. So it's not enough if you take out a part of the bone, osteochondroma, a part of the osteochondroma, leaving the cartilage cap behind. Once you do that, then there is a chance that this tumor may recur. So once you plan to operate on a osteochondroma, then or exostosis, then you should make sure that you remove the cartilaginous cap along with the tumor. Then only your operation will be a success. So this is a clinical example where a patient has a knee swelling. Okay. All of you can see the lower end femur here is swollen. So a patient has a tumor there. So this is peroperative. So once you open the planes, then this is the swelling. This is the swelling osteochondroma which projects out of the wound. And this is after excision. So see the size. So this is the cartilaginous cap which is there on the 3 o'clock position. 3 o'clock position, that is the cartilaginous cap, and this 9 o'clock position, that is where it is attached to the main bone. And this is the size. It's quite huge as the swellings go. Okay. So this is about osteochondroma. As the weather is a bit chill, even birds are covered. So what I suggest is, once the class is over, take out your textbook and go through these benign bone tumors or bone tumors in general, and osteochondroma in particular. And if you find any queries, or if you have any doubts, then you can always reach me. You can mail me, or you can send a message in my WhatsApp, so that I will be glad to clear your doubts. So this is about benign bone tumors, the commonest being osteochondroma, and we'll go to other bony tumors in our next classes. Thank you.